Thank you, Neha. Hi, my name's Sophie. So I'm a paediatric palliative care registrar at Great Ormond Street Hospital. So I'm just going to talk to you today a bit about end-of-life care. It's a kind of heavy topic for just after lunch on a lovely sunny summer's day, so I apologise for that. But if at any point you want to kind of stop me, I can make this session as kind of interactive as you want, and I can kind of tailor what we talk about depending on the things that you may or may not all be worried about. I definitely remember when I was transitioning to being a registrar, this was the kind of thing that terrified me the most, was a very unwell patient dying overnight when you're the kind of only registrar in the hospital is sort of your worst nightmare. So hopefully we can kind of make that seem a little bit less scary. Let me just see if I can move on my slides. There we are. So yeah, I guess just to start off asking you what kind of worries you about being the registrar and looking after a child at the end of life. I wondered if anybody had had any experiences thus far, things that had worked well or really hadn't worked well. Feel free to kind of turn on your cameras or just talk if any, or pop it in the chat if anybody has any particular worries. It's always harder doing it online, but
I can read out any of the comments in the chat.
thanks. We used to do this session face to face, and I think it's just a bit easier to kind of for people to talk a bit about.
Yeah.
Yeah,
so
having a plan in place.
Yeah, you can read it. Good.
Yeah, having a plan in place in the day team if possible. Yeah, absolutely. And we get that a lot in I've just seen a patient on the ward where the junior doctors were saying exactly that, like, please can we have a clear plan, because it feels very overwhelming if things change in the middle of the night. Yeah, and as much as possible we do try to do that, put plans in place, but sometimes things can change or things happen unexpectedly, and that's when it's kind of scary. Yeah, other people have said knowing what to do. Absolutely, I think it can be really overwhelming. Consoling parents and the team, making them comfortable, no pain, and feelings of care. So exactly, just I guess discussions about limitations to treatment. What if I feel helpless with feeling I'm trying to do my best when it's not working as part of end-of-life care? I think these are all really good points, and the things that kind of all of us are worried about. And I think even as an ST8 in paediatric palliative care, I've been doing palliative care for sort of over 4 years now, these are still the things that worry me. So I guess it's kind of just to reassure people. I think often there is a lot of emotions obviously coming from the family, but also emotions coming from the staff, and managing all of that can be really difficult. And managing symptoms can be tricky, and we don't always get it right. And seeing any child in distress can be really difficult. Just another comment here, challenges parents change their mind about end-of-life care and want escalation. Yeah, again, I think that's another really tricky kind of thing. So we might make plans early in advance. We might make an, fill in a respect document or make advanced care plans, but quite often parents change. And as we know, these forms and things that we sign aren't legally binding. And, the situation is often a kind of acute evolving thing when a child deteriorates. So I guess it's about having the confidence to kind of manage that uncertainty and know who to go to kind of ask for help if you're not sure yourself what the next sort of best step is. So thank you everyone who's kind of contributed there, because I think hopefully those are some of the things that I'm going to cover in this session. And I would definitely kind of echo that. I think the things you're worried about is what everybody's worried about, however senior they are. So really, really normal. Just trying to move my slides on. So yeah, the first thing I'd say, I guess, is it's okay to kind of feel scared about this. It's okay to feel really sad when a child's approaching the end of their life, or when a child dies, either sort of suddenly or when it's an expected death. It's okay not to know what to do, and it's you know, okay to kind of need help and support in these situations. Just because you're the registrar, people don't expect you to have all of the answers in these kind of scenarios. It's also okay not to feel these things too. So I think, you know, everybody's different, and every particular child will affect you in different ways, and you may be more or less sad or emotional about different children for different reasons, and that's also okay. Probably most important messages are to just ask for help if you're not sure. Show compassion to the families that you're looking after, and I think you will never go wrong if you turn to a family and sort of show sort of care and compassion, even if you say to them quite honestly, I don't know what the next best thing is, or I'm not sure I can necessarily solve this symptom right now, or I don't know the solution, but I will work with you and try my best to try and help. I think as medical professionals, we often feel like when a child dies, it's a failure of some sort, and that it reflects on us or the care that we're delivering. But it's not. It's kind of unfortunately just a difficult part of the job that we do. But I guess our job is to really try and make it the least awful that it can be, to make sure we take care of the patient, but also the family around them, and to take care of ourselves and our colleagues in these situations. And as you kind of transition into more of a leadership role as registrars, your role will also be in supporting your junior colleagues and in supporting the nursing staff and other staff around you. So that's a kind of new role to kind of think about. So I'm just going to today go over a bit about emergencies versus expected deaths, kind of what the normal procedure is after a child death, a little bit about the child death review process and how that works, talk a little bit about palliative care patients, and sort of how we make plans, and a bit around symptom control. If we got time, I'll talk briefly about organ donation, and then I just want to spend a bit of time at the end sort of thinking about how we look after colleagues and look after ourselves. But as I said, really happy for anyone to interrupt at any point. I'll try and keep an eye on the chat, but Neha, if you see anything pop up, you know, feel free to put things in if you've got questions as we go. And keep an eye on the time as well. So I guess emergencies kind of versus expected deaths. I'm sure you can all think of some examples of these, you know, so your emergencies might be middle of the night, respiratory arrest, a trauma call, sudden sort of unexpected death in infancy, whereas your expected deaths are more likely to be patients who are known to maybe known to a palliative care team already. They may have a progressive disorder, so you know, they may have an oncological diagnosis, but we also look after lots of children with progressive neurological metabolic conditions. I guess it's thinking about, as a registrar, how you might approach these situations differently and what you need to do for both of them, and kind of what steps you have to go through in each of those cases. All of them need good communication. That's probably the number one kind of thing to remember, in that actually communicating well with the family and with the team around you is going to be the most important kind of thing that you can offer. Showing, as I said already, sort of showing compassion to the family, and being careful about your documentation. When I was a registrar, I had several cases which ended up going to the coroner's court, or a safeguarding case that went to court. And actually by the time it went to court, it was quite a lot, you know, it was like over a year later, and I really relied upon the documentation that I'd written at the time. So really helpful, particularly if you have a sense that this is something that may be investigated later. Make sure you just take the time and write really good notes in the hospital notes, but also sometimes it's helpful if you've been involved in a difficult death to just go home and make your own notes and just kind of keep them at home, of just things that you remember, because it's amazing how much you forget quite quickly. It's important to know that all deaths need to be reported to the Child Death Overview Panel Secretariat in the local authority where the child was normally resident. So that means if a child who lives in Lewisham dies in Great Ormond Street Hospital, it still needs to be reported to the Lewisham CDOP. And it's usually, there'll be a discussion around it, but it's usually the case that it's the local CDOP who will investigate the death and hold the Child Death Overview Panel for that death. In an emergency, I mean, I'm sure you all know about running resuscitations, but if it's an emergency situation where the child looks like has died or looks like they're going to die, you know, get hold of your consultant as soon as possible, and it will usually be a consultant who would in hospital, and they will make the decision to stop resuscitation. So I think you shouldn't be worried about that as a new registrar, thinking that that would be your responsibility. Really helpful if possible to have someone assigned to support and update the family at all times, and it's a decision about whether the parents will be present during a resuscitation, but I think a lot of the kind of research shows that where possible, families find that easier if they are party to some of that resuscitation process, to feel as if everything has been, they've witnessed everything being done for their child. These are kind of your basic steps after a child dies. So you would need to confirm the death, make sure you document the sequence of events leading up to the death, and then you should have local hospital protocols which you follow, which will tell you kind of any other forms that need to be filled in, notifications that need to be made, and who you need to contact. So my suggestion would be, when you start your new jobs, is just make sure you find out where these protocols are. And there's usually, we always used to have a purple box in Lewisham A&E where I worked, or it was called a when a child dies box, and in there's usually all the folders, sort of protocols and information and forms that you need. A lot of the forms these days are now online, but you should still have a repository of kind of information somewhere. If the coroner needs to be informed, you would do that as your next step. That can, if a child dies overnight, that can be usually done sort of first thing in the morning. And then if you're able to complete the medical certificate of cause of death, most of the time it'll be a consultant who's completing that. So you wouldn't be expected usually to complete that on your own. And if you are completing one, you usually discuss what you're putting on the death certificate with your consultant, because we have quite a lot of cases, particularly if Muslim families want to bury their child quickly. If there's a mistake on the death certificate, or if they don't accept it, that can really delay things. So it's probably more important to check and make sure you get it right before writing the wrong thing on the form and causing delays for the family. And then thinking about any memory making activities, so handprints, footprints, photographs. There are charities available who can, particularly on neonatal units, come and take photos of the baby after death if that's something the family want. Just briefly talk about the child death review process. So this changed back in 2018, but because of COVID, it's sort of, I think the system, the new national child mortality database, which is now online, I think it went live in April 2019, but there was a bit of a delay because of COVID, everyone kind of getting up to speed with it. But it's now very much sort of up and running, and most trusts will use the ECDOP kind of forms. So they used to be called Form A, Form B and Form C. They're now called a notification form, a reporting form and an analysis form. And usually your responsibility would just be to complete the notification form, which is the old Form A, and that one needs to be completed immediately after a child dies, and it's actually usually pretty short, and it's just basically a notification to the CDOP secretary that this child has died, and then they will gather information before filling in the next sort of two forms, and different people usually sort of feed into those forms. Every local area will have a designated doctor for child death, so it's helpful wherever you start working to find out who that is. So it may be someone who's based within the trust, or it may be someone who's linked to the trust. They may be a community paediatrician, for example, but useful to find out who they are. And we're not always very good here in palliative care at making sure we notify them, but they should also be notified every time a child dies in their area. With the new system, there's been a real focus on identifying a bereavement key worker for families. And that's a sort of single point of contact for a bereaved family. And they should be able to turn to that person for kind of any information about the child death review process. They can signpost them to sources of support, and they can kind of feedback if they're kind of waiting for information from a coroner's investigation, for example, or if they're waiting to hear back the outcome of the CDOC panel. That bereavement key worker will be the person who feeds back to the family. This just kind of outlines the process that you kind of need to go through. So after a child dies, you're immediate kind of making decisions, and decisions, that means, are you able to fill in the death certificate, or do you need more information? Does the death qualify for a joint agency response, which is sometimes known as a JAR? We'll talk about a JAR, and that's any case where the death kind of is suspicious in any way. So if this is a sudden unexpected death, could the death be due to external causes? Are there any kind of suspicions around the death not being natural? I think the other cases are if it's a stillbirth where no healthcare professional was in attendance, or if the death occurs in custody, or where the child was detained under the Mental Health Act. All of those need to go to a joint agency response, and that involves the police and social workers and so on and so forth. But if neither of them are the case, if you're happy to fill in the death certificate, you would make your notifications with your Form A, you would let the designated doctor know. And then there's a process that kind of carries on behind the scenes of investigation and information gathering, where they get different people who may have been involved to fill in the second form, which used to be the Form B, like now the reporting form. And then they hold a CDRM, so a child death review meeting. And if you were involved in a death, you may be invited to that child death review meeting. And I'd really suggest, if you get the opportunity, if you're invited, to go along to one of these meetings, because it's often they'll invite the GP, local hospital, all the people at school who knew the child. And it can be quite interesting. You learn a lot more about families and the circumstances around that death. I remember going to one when there was a sudden like a cot death that I managed as a registrar, but then I went along to that meeting and found out lots more about the family and kind of the circumstances behind it, and that actually really helped me deal with that death. And then sort of at particular time points in the year, the child death overview panel will meet, and at that they review all the kind of deaths that have happened over a time period. And that's really looking about kind of things sort of preventative. It's more of a kind of public health exercise, I guess, to see if there are any kind of preventable causes or things that could be looked into to kind of prevent deaths in the future. So you may meet paediatric palliative care patients, so when you're working on the wards, or they may present to A&E. So these are children who are known to have life-limiting or potentially life-limiting diagnoses, and who are referred to a paediatric palliative care team. And usually paediatric palliative care will have done some work around advanced care planning, and that may be some children hold a kind of handheld advanced care plan, like a document, and the CYACP is the kind of document they're trying to start to use nationally, but we don't actually use it here at GOSH. Often we just have sort of discussions with families and document those, but it's helpful to know what plans are already in place or what discussions have been had. If you're seeing them on the ward round, try not to leave them till last. After your kind of high dependency patients, these children should really be your priority. I think families often reflect back to us when they're in local hospitals that they feel like, maybe because people feel a bit afraid of the situation, or it's a bit uncomfortable, or they're worried about bothering the family or getting in their way, they sort of tend to avoid them. And I think that can often be more distressing for families. So really sort of think about actively keeping them comfortable. We talk about paediatric palliative care as being an active approach to management, so it's not just about stopping. So even if you're withholding certain treatments, you're not withholding care, so you continue to kind of care for this family. consider sort of correcting the correctable or reversing things that are reversible. Just had a discussion with a neurology patient who's not for a resuscitation, but the ward team didn't quite understand why we might still give antibiotics for a chest infection. And we just sort of had to talk about the things that actually, if it's not troublesome to this child, treating their chest infection, if we think that that's a reversible cause of a deterioration, you know, is entirely appropriate. And with all treatments or interventions, you're just weighing up what are the potential burdens to that patient, but also the benefits. This is come out of the NICE guidance, which from 2016 on end-of-life care for children and young people. And I guess it just highlights kind of our approach in paediatric palliative care, rather than in sort of adult palliative care where you might just be involved in looking after a patient at the end of life. Our approach is very much kind of being involved from the point of diagnosis of a life-limiting condition and supporting that family through care planning, through delivery of care, through the specific end of life phase, through death, but also through bereavement. And it just talks about the sort of different roles that we have at all those different stages. I think it's also important to say that paediatric palliative care is not just the business of sort of specialist teams. So everybody is responsible for delivering paediatric palliative care, and we count kind of local paediatricians, community nurses as part of the paediatric palliative care team around the child. So important to kind of think, if a child is approaching the end of life, have there been discussions around their preferred place of care and their preferred place of death? So for some families, they feel more comfortable in a hospital setting and would prefer to stay there. For others, it's really important for them to be able to get home, to spend time with their child at home before they die, or even to have their child die at home in a more sort of familiar and comfortable environment. And children's hospices are often a good kind of bridge between those two. If it's too frightening to be at home and they want some support around them from medical professionals, but in a bit more of a home-like environment. Try and do what you can to kind of make these things happen, but don't make any kind of assumptions or promises about what you can offer. So we've had cases in the past where, you know, teams might say, oh, well, you can go to the hospice if you want to, without actually checking that there is a hospice bed or that there's availability of that. Often, you know, we have issues with staffing, filling care packages in the community, you know, staff shortages in hospices. So sometimes, despite our best intentions, it's not something we can offer. So it's best to check what is available before you offer it to the family. And we're always happy to kind of make those calls ahead of time. So if you get in touch with a specialist team, they can usually do some investigating around that for you. Thinking about kind of what limitations to treatment have already been agreed. So I think that was reflecting on what somebody said in the chat about, you know, really good to have a plan in place beforehand, particularly for a night shift. I know it's helpful to sort of know, you know, if this child deteriorates, am I doing blood gases? Are they for IV access? What respiratory support would we offer? So that might be, we usually never say no resuscitation whatsoever. So most of our respect documents would say that we would always offer oxygen for comfort. We'd always offer airway repositioning and suctioning. Some children we might offer non-invasive ventilation, even if we would say they're not for intubation and ventilation and not for CPR. So good to kind of have those discussions ahead of time if you can. And often these are difficult discussions and need revisiting on kind of multiple occasions. So you might not always get the answer from families, and that can be difficult because then you do sort of have to sit with a bit of uncertainty and perhaps sort of decide at the time. And I know that often feels uncomfortable for professionals. Thinking about kind of medications, if we know a child's approaching end of life, we try and rationalize medications as much as possible and really only focus on the ones which are providing some sort of symptomatic benefit. We think a lot about routes of administration. Most things can be given enterally, even kind of right up towards the end of life. If children have an unsafe swallow, a lot of them have an NG tube. So as long as they're still absorbing enterally, we try to use oral medications or some buccal medicines. Some of our children in the end of life phase sort of lose enteral absorption, and then we tend to go for sort of subcut administration if they don't already have a permanent IV access, to sort of avoid unnecessary cannulas or procedures. Really good source of information is the Association of Paediatric Palliative Medicine formulary. You can just Google it, it's available online, and it has all doses around symptom management medications, and that's kind of our Bible that we use. Just conscious of time, so I'll just kind of whiz through this a bit, but as I said, thinking about keeping medications to a minimum, thinking about non-pharmacological treatments. So a lot of the things that we do actually don't involve drugs. So children who are breathless, for example, often buying a small handheld fan can really help with that sensation of breathlessness. Children who are anxious or agitated, a lot of that is around kind of providing an environment where they feel safe and kind of comfortable. You know, I found going home and having, you know, being surrounded by your toys and your family tends to work a lot better than buck or midazolam for settling most children. There can often be difficult conversations around hydration and nutrition. Children's requirements for fluids and calories will naturally tail off towards the end of life, but it's important to still keep them hydrated. And if they have a prolonged end of life phase, to think about their nutritional status. And we can often work with teams to kind of think about sensible, pragmatic plans for that. And where possible, give analgesics regularly rather than sort of waiting till a child's in a lot of pain and having to kind of play catch up. So if you have a child who is approaching end of life, or who's already known to a palliative care team, please contact us as soon as possible. We can often give you a lot of background information, can support and advise with symptom management. All of the paediatric palliative care teams in London have a 24/7 out of hours telephone advice on call service, so you can always contact us at any time of day or night. And we can also help with liaising with hospice and community nursing teams, particularly if you're looking around discharge. So those are just some of the resources I mentioned. So the APPM formulary there on the right, the end of life care NICE guideline, which was published in 2016, but is really worth a read if you've got time. And at the bottom is the framework for practice for making decisions to limit treatment in life-limiting and life-threatening conditions. It's published in archives, but it's freely available. And that, if you're interested in ethics, it's a really good kind of outline of the ethical principles that guide us when thinking about withholding or withdrawing treatments. I'll skip over this because I think we're just running out of time. These are just some more good resources for bereavement support for families. And I guess really just going back to the point about thinking about supporting yourselves and your colleagues when you're in these situations. So often just providing support and a space to talk for your colleagues can be incredibly valuable. So if you've been involved in a difficult resuscitation, if a child's died on the ward, where possible, try and kind of take a bit of time out, whether that's just saying, let's all go and sit in the staff room and have a cup of tea and just have a talk about how that felt for everybody. Because even people tend to just move from one thing and then go back to their jobs and ticking off the jobs on their list. And it's people do need a bit of space to kind of decompress after something like this, and a lot of the time those other things can wait, and formal kind of debriefs can come later and can be helpful, but I think that immediate kind of just decompression can really help everybody. And just thinking about other sources of support that may be helpful for you or your colleagues, so be that going to a consultant, talking to senior nurses, getting in touch with the palliative care team, and signposting to kind of occupational health or your educational supervisor if that's needed. And the same kind of principles sort of apply to us really, acknowledging your emotions, being kind to yourself. Be aware of when you kind of are burning out or kind of losing a bit of that compassion, because you've been involved in a lot of distressing situations. We get that a lot in our kind of roles, and have to really think about when it's time to take a bit of a break or take a bit of a step back, and what we can do to kind of look after our own emotional well-being. And you might all have different strategies for that. Just a Dr. Seuss quote. If anyone, sorry, did somebody want to say something there?
I think that was an accident.
Okay, no worries. If anyone's interested in paediatric palliative care, definitely get in touch. So I'm one of the trainee representatives on the APPM, and that email at the top there is our kind of generic email address. We run a 2-year rolling educational program, most of which is online now. You can anybody can enroll on the course. It's free. You can watch the kind of sessions in real time, or you can watch the recordings later, and we cover lots of different topics in paediatric palliative care, which are on our curriculum and on the SPIN curriculum. But if you're interested, just get in touch and I can add you to the mailing list and tell you how to enroll on that course. So that's our Paediatric Palliative Medicine Education Network. The RSM also do a palliative care study day, which is really good if you're interested. And the APPM run a kind of conference and study day every year, but we've just had the 2022 one, so the next one won't be until November 2023. And if you're interested in spin training or grid training, we do taster weeks here at GOSH. And I'm always happy to talk to people about training if you're thinking of applying and wanted any advice. I'm going to kind of wrap it up there because I'm conscious that I've sort of run out of time. But just to kind of reiterate the things I said at the beginning, it's okay to find this stuff really difficult, because it is really difficult. And it's okay not to know what to do, but just make sure you ask for help when you need it. If we've got a few minutes, I don't know if anyone has any sort of questions or anything that's worrying them that they wanted to talk about. I'll stop sharing them.
We do have another 10 minutes, actually. You've got till 15:15. So,
oh, fine, perfect. So
if there's anything
probably
else
good that I rushed through then.
If there's anything else you want to cover, or yeah, if anyone has any questions, then now's a good time.
I'll leave it. Yeah, no, that's good. Rather than you just listening to me talking about slides, maybe if anybody has anything they wanted to ask or anything they're worried about, really. Just give it a second.
Hi, I have a question, please. Thank you for your talk. I think it's more of about the logistics of things when we're working in a district general hospital, because I'm relatively new to London. So how capable, or say like district general hospitals here are of looking after end-of-life patients, and do you kind of provide support by coming into different hospitals and seeing those patients?
Yeah, absolutely. So most district general hospitals can manage end-of-life patients really well, sort of in that setting. So we tend to, it can often be, you know, if a child's already known to a tertiary hospital, so if they already know Great Ormond Street and come in here, there can often be a reluctance from families because they want to go to that specialist centre where they feel that their child's kind of better known. But there's not, you know, there's often no reason why children can't be managed in a DGH sort of setting, and we would actively kind of support that. So we do visits. We do visits to local hospitals. So if there's a child who's end of life, we would try and come and see them regularly wherever they are. So whether that's in a hospice, at home, or in their local hospital. As I said, we're also available for advice. So we have a lot of DGH doctors who call us, you know, regularly, multiple times a day, multiple times a night, to say, well, this has changed. I'm seeing this symptom. What should I do next? And if a child's on a syringe driver, we would be advising about all the dose changes for that. We wouldn't expect you to be managing syringe drivers on your own in a district general hospital, and we would be advising on any changes. The only cases where we've kind of had to move children into GOSH, particularly for symptom management, is if the management's really complex. If they're on things like a methadone infusion, we might get them across here, but most of the time it can be done locally.
Okay, great, thank you.
There's a few more questions come here. How to ensure clarity about respect form being a new reg, something I don't find if I'm looking for it. E.g., can I still offer Vapotherm if patient is not for to escalate treatment? Yeah, I think it's a good question. So I think as much as possible, when the respect document is completed, whoever does it, it's really important to kind of make sure that there is clarity there. So when I fill one in, I tend to really list the things that the patient is for, as well as the things that they're not for. So most our respect documents here have sort of 3 boxes at the bottom. One is for sort of no resuscitation, one's for full resuscitation, and one's for modified. And I always tick the modified one, because actually most children, as I said before, will always have some sort of resuscitation, even if that's just oxygen. But sometimes these things are about clarifying those discussions, and these things are also often a bit soft. So, you know, it might have no IV access ticked on there, but actually a child's got a prolonged life-limiting condition. They're dying slowly. You might say, oh, well, actually a few days of IV antibiotics is okay, and you might want to readdress that. So I think asking questions, asking for clarity and readdressing things is really helpful, rather than just being like, well, this is what it says on the form, means we just absolutely can't do it. So yes, I think you can always think about offering things like Vapotherm or other types of interventions. Hope that's helpful. Anybody else? Thanks. There are usually lots of things that are worrying people, so yeah, don't be afraid to ask. I haven't had to confirm a death for a few years. What steps do you follow? Yeah, so we don't actually do it very often in paediatrics, do we? I think when you were when I was a house officer, you sort of felt like you were doing it all the time on care of the elderly wards, didn't you? So it's okay to look it up. I usually go and look it up before I do it, but essentially you're just you know, checking that there's no reaction for the pupils, checking that there's no heartbeat, checking that there's no spontaneous respirations. I think you listen for over 2 minutes, and just make sure that you kind of document that you've done all of those things. Yeah, but look it up before you do it, so you go in feeling prepared, you know, because you don't want to walk into that room with a deceased child and their family and not feel like you're kind of comfortable with what you're doing. If anyone else has got anything. There's so many of you here, but I can't see any of you, so it feels unnerving. Yeah, a few more questions coming in. What is needed for the family to have the child's body back? So that's a good question. So most of the time, if you're able to, if there's no concerns, if the death doesn't need to be referred to the coroner, and if you're able to complete a death certificate, then once the death has been confirmed and the death certificate's been completed, it's fine to transfer the body. So we often transfer children's bodies after death. So sometimes to go back home to spend some time after death at home on a cooling mattress. Sometimes to go to a cold room in a hospice, where families may choose to spend a more prolonged period of time with their child after death, and for families to be able to, sort of relatives to be able to come and visit the body. If we have lots of contacts with transportation companies who do that for us. So Tender Touch is one of them, and they're you know, very responsive and very sensitive when transferring bodies. Sometimes we've had situations where the family want to take the body in the car, in their own private car, which is fine. But if we do that, we have to just make sure that they have a letter with them explaining that the child has died, that we've given permission for them to transfer the body. And that's just because if they're in an accident, or if they're stopped by the police or stopped for whatever reason, they have that documentation on them. Is there any advice, guidance on giving family time with the child after they've died? So yes, there's not really, I mean, so in the NICE guideline, there's a bit of information in there. There's actually very limited kind of guidance in most of paediatric palliative care. There's very little research that's kind of been done in our specialty. So there's not really a protocol as such, but we have lots of experience of kind of supporting families in spending time with their child after death. So we can usually give advice about that, and children's hospices are really good at advising as well. There's not actually a limit on time on how long a family can kind of spend with their child after they've died. We've had some families spend, you know, a week, 10 days. The body does kind of deteriorate after a certain amount of time, and usually after about a week, most families find that that's enough time for them, but we can kind of support and guide with that. Another quick query, no, don't apologize. Who to involve in decision making if parents change their mind in terms of palliative care when I'm the only night red child deteriorates and is not for resus. Yeah, so I think I guess that people wouldn't necessarily be, just to kind of clarify the terminology, it's not necessarily, so palliative care is not just end of life care. So parents might kind of change their mind around limitations to kind of treatments. But I guess palliative care also involves children who are for active resuscitation as well. But I guess your question is what happens if they change their mind about kind of what interventions they want. So I think the first thing is kind of just to explore those concerns with the family. So ask them what they're worried about, what their hopes, I just tend to ask what are your hopes for your child, what are the things you're hoping for, what are the things you're most worried about, and explore that. Because often, it can be, well, I'm worried about them being in pain, and you can kind of address that question, or I'm worried about, them dying and this person not being here, and it's kind of addressing those things. Sorry, just excuse me. So I'd explore with the parents what they're worried about, and then I would ask for senior help. So if they're known to a paediatric palliative care team, contact us, contact your consultant, and any sort of kind of resuscitation decision that's made in advance is not kind of legally binding. So parents are allowed to change their mind at the last minute. It doesn't mean that we are obligated to provide the treatment that they're asking for. So at the end of the day, it's always a clinical decision whether to go ahead with resuscitation. So if you strongly feel as a medical team it's not in that child's best interest, there's no obligation on you to do CPR for that child. But if it's in some situations, if it's very strongly what the parents want, it may be appropriate to do a short amount of resuscitation, even if that's a small amount of bagging, whilst they kind of come to terms with what's happened. You're welcome.